Next patient is a 66-year-old woman with a past medical history of lung transplantation in 2007. She has terminal chronic renal failure requiring peritoneal dialysis. She developed in March of this year acute abdominal pain and bacteremia due to Streptococcus gallolyticus, following a bacterial peritonitis treated by antibiotics. And etiology was unclear, therefore a workup was performed with a CT scan showing left ureterohydronephrosis with nephrolithiasis requiring ureteroscopy, and MRI showed 2 common bile duct stones with south common bile duct dilation. The lab test showed cholestasis but normal bilirubin level, and she's now asymptomatic. The patient is scheduled today for ERCP with stone extraction, and we will join now Dr. NEUHAUS and Dr. ARVANITAKIS.
Now, I already introduced the Duodenoscope. This is the TGF Q190V from Olympus. We have a nice view of the papilla. So it looks very friendly. However, it's not so easy to approach this papilla because it's deeply in the duodenum, and therefore I have to use the long root position to approach it. When I straighten the scope, I lose the access. So I would like to cannulate from a close distance, and for this purpose I'm using the Omnitome from Cook, and it's preloaded with an angled wire. This is, push the wire a little bit out to see the wire. This is the jack wire. Pull it back a little bit. Okay. So, and of course, wire-guided cannulation is the method of choice because in contrast to contrast injection, we have a lower rate of post-ERCP pancreatitis, and I prefer to try to get the tip into the orifice and then to ask this, bend a little bit. Okay, so try to push the wire forward. This is probably the, okay, we check. Okay.
You felt that you're in a duct there, huh? You felt.
Yeah, I'm obviously in a duct, but this may be the,
yes, maybe
the pancreatic duct because she has resistance. I try it again. Let me see. So I'm trying from here to get in the 11 o'clock position, and Leila is now bending the sphincterotome.
We usually work in supine position, but when we have a difficult position in front of the papilla, especially when it's difficult to be down to the papilla, we can of course turn the patient on the left side. But it's not.
You've seen what we did.
Yeah.
So this is of course so wonderful to work here. You have just to insert the tip into the papilla, and then the assistants, especially Leila, with whom I been working together for many years, she advanced the wire in the duct you would like to have it. So now, especially in case of a small stone, I insert the sphincterotome up to the confluence, because when you inject from the lower part of the common bile duct, then you may push stones upwards. So it's better to inject now at this level. Okay, inject the wire forward. I'm pulling the sphincterotome back, and until we see the wire coming. So, and now bending, and as you can see, when we have the green ring, means we have about 1/3 of the cutting wire inside, and this is a good position in 11 o'clock, and I'm maneuvering the position of the wire with my right hand, so I have the hand on the shaft of the endoscope, and this allows me to control the cutting wire. So I have a good control. So now I'm pulling the sphincterotome back a little bit.
So green is good, black is too in. It's too
Yeah,
deep
there's
in.
too much. Yes,
Yes.
exactly. So, and you can control it millimeter by millimeter. So I think we can also cut this fold.
That's the horizontal fold, huh?
Yeah.
So he's Horst is very nicely showing the landmarks of
Yeah.
the papilla.
Pillar. And you have seen that we cut the sphincter and had a direct look into the common bile duct. So the sphincter, the small sphincter had been cut. So therefore, it also depends on the length of the papillary roof. So now, please insufflate. Do you have the fluoroscopic image?
Yes, very well, very well.
Okay, so I'm pulling it downwards. So, and then I advance the scope a little bit deeper to pull it now in the extended axis of the CBD.
C'est Daniel. Ou alors Arnaud veut montrer la lésion avec l'EI pour montrer qu'il y a de multiples.
Yeah, there
Yeah,
it is.
there's a small
Yes,
stone.
a black stone, yeah.
So,
Ça va. Ok, très bien.
well, I will freeze it for you. Yeah.
He thinks
But
so.
very difficult. But
Yes.
you knew,
But this is a good example of the fact that ERCP is not a black and white imaging tool anymore. So the imaging can be done before, and we knew that we would go for a therapeutic procedure
Now the
from the
balloon.
start.
go, okay.
So you see here how Leila deflated the balloon and stopped pushing the guide wire to
Yeah.
prevent leaving the losing the guide wire.
Okay. One more time. But I think it was only a small stone.
Yeah, it was one stone.
Insufflate again, Leila. Maybe there was small pigment stone.
Do you think there's indication to flush? Oh, there's something more maybe there. Yeah. there's
Yeah, another one
Yes.
coming.
This is not so small, huh?
No, it's not so small.
So it's good.
So, Horst, thank you very much for this very convincing and nice presentation. Everything looks very easy when you do an ERCP. Thanks, Marianna, also, and all the team. We just move now for the presentation of the next case.
Okay, thank you.